You can sleep in.
All right, let's reconvene the impeachment hearings. Keep trying to prod the people on Upper Campus to call me in for saying politically inappropriate things, and I think no one's listening this time in the morning. All right, so we have two speakers. Originally, Clint, first-year fellow, is going to have the whole hour. Is going to talk on eosinophilic GI diseases, and he will do that, but he's going to divide it into a session. Today, half of it, he'll be the second speaker today, and then later in the year and come back. So we have a visitor from San Francisco. I presume it's warmer down in the city than it is here.
I think it's a little warmer,
yeah. Yeah. Karen Anstey, that's close anyway, is visiting here. She's going to give us a presentation on drug allergy, penicillin, and beyond. And she'll get about half the session, and then Clint will come back and do the second half.
Well, thanks for having me, and Clint, thanks again for letting me do part of my talk today. So I am going to talk about drug allergy, penicillin, and beyond. I have no disclosures. So just to get us all off on the same start, so I wanted to talk a little bit about Beta-Lactam antibiotic allergy, which I think is going to be a review for a lot of us, and then go into the most recent literature in this topic. So penicillin allergy, the prevalence. So we know that it's reported in about 10% of patients in their allergy list, but we also know that about 90% of the patients, if you actually test them, have negative skin and intradermal testing. And so we think this is due to one of two things happening. One is that the allergy could have resolved over time due to natural waning of an IgE mediated allergy. So we know that in patients with initial positive testing, if you test them 5 years later, 50% of them have negative penicillin skin testing, and 80% of them have negative skin testing 10 years later. Or that the patient just reported an original reaction that wasn't a true IgE mediated allergy. And then cephalosporin allergy, much less common than penicillin allergy, so it's reported in about 1.3 to 1.7% of patients. And it's possibly estimated that this may increase over time as we continually use more and more cephalosporins, especially in hospitalized patients. And then the antigenic components and beta-lactam allergy. So we originally thought that this was probably due to the beta-lactam ring, which is shared between penicillin, cephalosporins, carbapenems. But in the more recent years, we found that it's most likely due to these R group side chains. And I always like to point out that aminopenicillin, so amoxicillin and ampicillin, have similar side chains to several cephalosporin antibiotics. So it's always something we should keep in mind if a patient does have a true amoxicillin allergy. And then penicillin allergy, a lot of what we do is evaluation for IgE-mediated allergies with skin testing. So penicillin skin testing is the recommended test of choice with a negative predictive value of 97 to 99%. Notably, the studies with this negative predictive value were not done in the United States. And so, as we know here, we only have PrePen and penicilloyl. And so we don't test for two of the minor determinants, which are lower on the slide. So that's part of the reason why we do an amoxicillin challenge, is it results in these similar negative predictive values, so a really great negative predictive value in the end. But it also tests for sensitization to aminopenicillins. And a lot of kids get amoxicillin when they're younger and have a listed amoxicillin allergy. So it's always great to test for those at the end as well. And cephalosporin allergy. So how we evaluate, so this is much more difficult because we don't have a lot of determinants like I was just talking about in the penicillin allergy slide. And then there's also minimal studies that have evaluated the sensitivity and specificity of cephalosporin skin testing. So we don't quite know how great of a test it is. The other question that comes up is the ideal concentration for skin testing. So a lot of people use different concentrations and it's not totally clear. A lot of studies have used concentrations of about 2 mg per mil, but clinically people use anywhere from 2 to 33 mg per mil. And some people say, well, lower concentrations lead to less irritant skin reactions. Some people say oh, we should use higher concentrations because it reduces the number of false negatives. So it's really difficult to tell exactly what we should be testing with. And then one thing I always like to remind us is that we should consider testing for cephalosporin with a dissimilar R1 group side chain because of the cross-reactivity, in addition to the possible culprit agent, just in case they have positive skin testing, and then you kind of can find a most likely agent that they won't be allergic to if needed. And then cross-reactivity. So original reports of cross-reactivity between penicillin and cephalosporin were about 10%, but as we know, that's not true. So the actual rate is about less than 1% in most recent studies. And we already talked about how side chains are considered to be responsible for hypersensitivity cross-reactivity. There was a recent article in JACI in Practice that included basically T-cell mediated reactions, so kind of delayed reactions, as well as IgE mediated reactions in their meta-analysis and papers to see what the cross-reactivity may be. And they did find that it was a little bit increased for this. So 16% for aminocephalosporin, so that kind of original side that I was showing you between amoxicillin and ampicillin and some of the cephalosporins, and maybe a little bit higher for these T-cell mediated, or this category with the T-cell mediated reactions included, so maybe about 2% with those without similar side chains. And then for carbapenems, less than 1% cross-reactivity, and that was confirmed as well in this most recent article, which included T-cell mediated reactions. And for monobactams, there's no cross-reactivity. I always like to include here that ceftazidime does share a common R1 group side chain to estranium. So remember that with an AZ and AZ in both of the antibiotics. That's one that you should always keep in mind, that there is, they share that common side chain. And so there might be cross-reactivity there. And then cephalosporin. So we really like these charts that show us the common, either similar or the same side chains to determine which of them may have cross-reactivity. So on to the more recent studies in beta-lactam allergy. So beta-lactam pathways have become more and more common in the hospitalized population. So this is a guideline for any provider basically to talk with the patient about their antibiotic allergy, determine how high risk or low risk that may be, and then possibly give them a beta-lactam allergy with beta-lactam test dose without even talking to an allergy provider. So why these were developed is that cephalosporins, as we talked about, are the most commonly used antibiotic in hospitalized patients, yet many patients have a listed penicillin allergy. And so we found that in patients with a reported penicillin allergy, they have longer hospital stays, receive more other antibiotics with side effects and that are stronger, so or more broad, so fluoroquinolones, clindamycin, and vancomycin. And these patients also have more C. diff, MRSA, and VRE infections. So as these clinical guidelines came out, the question came, what is the safety of these clinical guidelines that directs non-allergy providers to take a history and prescribe antibiotics for patients with a penicillin or cephalosporin allergy? So Blumenthal et al. Developed one of these guidelines over on the East Coast and followed safety data pretty recently. And so they took their cohort of patients from 2016 to 2017. They included 5 hospitals, so 2 academic and 3 community hospitals. And they found that there was about 1,000 test doses in this amount of time. And as you might expect, a lot of them were to cephalosporins. So 77% to cephalosporins, 14% to penicillins, and 9% to carbapenems. So a pretty successful intervention.
What do you mean by test doses? What was actually done?
Yeah, so that's basically giving like 1/10 of the dose of antibiotic, followed by a 30-minute wait time, followed by 9/10 of the dose.
No skin testing, just taking the history and giving a partial dose?
Exactly. So these are just, in this study, it was about 40% internal medicine hospitalists that just followed the guidelines, which I can show you in a few slides, and determined that it was probably safe to just do the test just on their own.
I mean, ID people have always said the history isn't anaphylaxis, just go ahead and use the drug. they don't have the same guidelines we do. So do they remove people with a convincing history of anaphylaxis and not give them a test dose?
It depends on what antibiotic you would be giving. So if I go forward a few slides, just to kind of jump ahead and then I'll go back. So like what you're talking about is like high risk for allergic reactions.
Most convincing history of anaphylaxis.
Yeah, so you can give kind of test doses to what we think is not cross-reactive, so 3rd to 5th generation cephalosporins, cefazolin, and carbapenems as far as a penicillin allergy. So if they had a history of, for this pathway that we use at UCSF, if they have a history of anaphylaxis to penicillin, you can still give a test dose to those antibiotics, but you would be consulting allergy for anything else. Okay, quickly about the safety of this. So what they found is that 7.5% of these 1,000 test doses had signs or symptoms of an adverse drug reaction during the challenge. But when they actually went back, this was kind of my chart review, when they actually went back, they felt like only about half of them had confirmed hypersensitivity reactions. Interestingly, about 70% of them occurred on a second step, so on the higher dose rather than on the kind of baby smaller dose step. And then about 50% of them had pretty mild symptoms. So 58% required absolutely no treatment beyond drug discontinuation, so just turning off the drip. And only 3 patients were actually treated with IM epinephrine. And so internal medicine is probably the most common service that orders these. So in this study, it was about 45%. And then AI was consulted only for 9% of the challenges for assistance. And then I think one of the things that always pops up when we talk about this stuff is like how people are updating the allergy record, especially if allergists aren't involved. And so they found that the allergy list was only updated about 45% of the patients. So a lot of patients received test doses and evaluation and didn't receive any kind of like update to their allergy record. And so they found within this 45% that the records were specified. So an additional comment was made under their penicillin allergy that they tolerated a cefepime test dose, and like 82%. It was actually deleted in 16% and then added at 8%. I think it is appropriate a lot of times, you know, then we're not necessarily doing a test dose to penicillin in a patient with a penicillin allergy. And so I think it's fair that a lot of the records are specified rather than deleted, but it's still a large percentage that aren't receiving any kind of addition to their allergy list or additional records to their allergy list.
So half the time, nothing's done. We do testing, we prove they're not allergic, and nobody changes the record.
Yeah, so, you know, in a cancer patient that comes in and they have, they've tolerated cefepime or something for their neutropenic fever, even under the penicillin allergy, you could say tolerated cefepime and then just give them full dose cefepime next time they come in. But about 55% of the time, we're not even doing that. And so that's a little unfortunate because then you either have to go back through the record or give another test dose to cefepime or use other antibiotics. Yeah. And so within this, the group has used clinical decision support. And so when they, when a provider orders like a clindamycin or one of those kind of red flag antibiotics, or aztreonam is also a common one here, this pop-up flags in these best practice advisories, flag an EPIC, and then kind of guide the provider to this pathway that I just showed you, and then they can kind of decide on what to do. And they have kind of really easy to use order sets and descriptions of how to take an antibiotic allergy. I think this comes down to how many clicks do you want for providers, and at least at our at UCSF we haven't started these best practice advisories because there's just additional clicks for providers and has been really difficult to implement. And then this is our pathway specifically at UCSF. I didn't include the one included in the study, but we were just kind of showing before. The left-hand side is a patient with a listed penicillin allergy. The right-hand side is cephalosporin allergy. And so one, it directs providers to ask about, like, how do you ask about, in this whole guideline, how do you ask about allergies and how do you determine if it's high or low risk? And then from there, kind of what providers can do on their own and what providers have to consult or we suggest consulting allergy for. And then we have a test dose order set as well in our system where it's pretty easy to order a test dose for patients on the floor and on the boards. So recent studies in low-risk penicillin testing. So I think direct oral challenges are now becoming more popular as we're talking about patients with like low-risk penicillin allergies, so maybe just a delayed rash. And so as these become more popular in delabeling the low-risk individuals, I think it's really important to determine what is low risk, because I think we all have kind of different determinations of what is low risk and what is the actual safety of this. And so there was another recent study in JACI. This was the first randomized control trial published very recently. And they define low risk as children, so 5 to 18 years old with cutaneous only reactions greater than 1 year ago, and so adults with cutaneous only reactions greater than 10 years ago. And notably, cutaneous only reactions could include urticaria or hives. And so they had about 159 patients and they randomized them to skin testing versus an oral challenge. And I always like to include the dose here because this is always debated as well. So adults received amoxicillin 40 and then 400, and children were either 20 and 200 or 40 and 400, depending on age, weight, and provider preference. They utilized a two-step challenge with a 30-minute wait in between the two doses and after the second dose. And then their positive skin test is notably 3 millimeters more than the saline control, and I think this is debated as well, whether you use 3 or 5 in your positive, determining a positive penicillin skin test. And so what they found is that more patients undergoing penicillin skin tests had positive evaluations as compared with just giving them the medication, but this was not statistically significant. And then they found that only 3 patients, so out of these 159, 50% of them were randomized to this arm, had immediate reactions with the direct challenge. All were treated with an antihistamine, so all were very mild, and none of them required an epinephrine injection. And then recent studies in delayed reaction time. Yeah.
The point, I presume, of this study was you learn anything more from skin testing or going just to a direct oral challenge?
Right.
I don't get the punchline, so did
Yeah.
you learn anything more?
So the punchline is, I think it's a little bit, this study is a little bit difficult. It was the first randomized control trial to come out. So it does seem like more patients are delabeled if you go directly to a direct oral challenge. But the question is they use kind of a low, this 3 millimeter cutoff for positive skin testing. So that's kind of debate, that's been questioned about whether they were overcalling positive skin testing in
So
this
they had a
study.
positive skin test, did they not go ahead with the challenge?
Exactly.
They did not.
Yeah. Yeah.
Actually, this goes back to the very first slide. I was actually talking to a resident about this yesterday, and I don't know if anybody knows this answer. When we say that over 90% of people with a history are negative when we test them, and then the question is, do they have penicillin allergy that disappeared, or they never had penicillin allergy and it was a false reaction? And the studies that say like 90% is a curve where over 10 years virtually it all dissipates. It would seem to me that that's only correct if you skin tested them when they were young children and they had the reaction. You have to have a proof at the beginning to know that it went away. You never have that. I mean, all the histories that we get, I had a rash when I was 3 years old, but that was never documented. So we don't really know that anything went into attrition. They may never have had a reaction. So does anybody know how to make that distinction? Do they truly have penicillin allergy, or I always assume it's just a mistake. Somebody called a rash an allergy, which it wasn't. and there was no attrition because there was never any true penicillin allergy in the first place. Anybody know that answer? I assume that no one knows. And it hardly matters, but
Yeah.
I don't know the answer, but hives are very common in children who have viral infections of all
Right.
sorts.
Right.
So I think what happens is that somebody's an ear infection and the hives, and at the same time he's getting an antibiotic, and it's attributed to the antibiotic.
so here's the head of ID. So always taught that you guys just, the history isn't anaphylaxis and they're sick inpatients, you just give the drug. You don't mess with any of this.
We don't, but
There you go.
we could. We don't give that drug. So unless, so for example, if they have a history of a rash to a penicillin, we're gonna go ahead and give a cephalosporin. But we wouldn't give a penicillin probably.
Yeah, well, that's the point, though. Might be better to give the penicillin, it might be cheaper, and you might not be using drugs that you prefer to hold for another situation.
Correct.
Right.
Yeah,
Just to stir the pot a little bit, back to old days, we used to diagnose mononucleosis by giving people penicillin and see if they turned red.
Yep.
And if they turned red, they had mono, and if they didn't turn red, they didn't have mono. It had
Might
nothing
be
to
better
do
test
with
for that.
allergy, it was just the drug reaction to the infection. So,
Right.
I mean, I bet you all 90% of those people were never allergic.
yeah, that's what I
Right.
assume.
So the answer is probably no, but was there anything unique about the three patients with immediate reactions? In other words, they had a rash on day one, was more urticarial or not? No.
They didn't mention that, yeah.
Okay.
That's an excellent
No.
point. All right. And then the recent studies in delayed reaction testing. So a lot of patients talk about kind of delayed rashes that they might be having to antibiotics. And so one of the questions comes up, is there added value to kind of this postpone prolonged challenge to diagnose non-immediate penicillin hypersensitivity or non-immediate kind of rashes? And so there was a recent study with 116 patients that underwent these extended challenges of amoxicillin. And so what they did is they did penicillin skin testing and an oral challenge. They waited a week, and then they started this 7-day kind of course of amoxicillin. And so their dose was 250 milligrams twice a day for 7 days in adults, or 50% of the challenge dose twice a day in children. And so notably, 2 of the patients had a rash during the washout phase of 1 week. So they had penicillin skin testing, they got the single graded challenge dose, and then they developed a rash even after that. And then they only identified 1 additional single patient that demonstrated a mild rash afterwards.
You didn't have a control group that they gave placebo,
No, they did not.
so you could just argue these are random rashes.
Yep.
They might have been drug induced.
Exactly. So we don't typically, at our institution, do these kind of delayed challenges, but I think there's kind of minimal utility to doing this because they're not very typically scary rashes. You really shouldn't be doing challenges in patients with severe cutaneous adverse reactions. And so we don't do these in our institution, but it is interesting to talk about.
Is there any literature about trying to figure out a way to test those people? Because they're the only people that I stay away from, are the people that have Dress or Stevens-Johnson. We won't test them at all.
Yeah.
So you have any delayed testing, that there's any literature that we can test them?
So there is some literature more from the patch testing side in that. So if a patient like had SJS or Dress or like a fixed drug eruption or something like that, you can actually do some patch testing. It's kind of minimal literature at this point. So our dermatologists at UCSF do patch testing to drugs to try to determine what the culprit agent may be. But it's also scary, right, to re-challenge antibiotics that were negative on patch testing that might have caused these reactions.
So we don't have any help there.
Yeah, I wouldn't jump to it, at least for SJS or, Dress at this point. And then targeted testing has been also a hot topic recently. So many antimicrobial stewardship programs focus on kind of like these delabeling of antibiotic allergies. with more focus recently on these kind of targeting high antibiotic user populations, which I think you guys are doing here as well. So the prevalence of listed allergies is not only higher in this population, but they also require more antibiotics than typical patients. And so it's a great kind of area that we can help out with. So there was a recent study on inpatients with a hematologic or a GU malignancy. And so in malignancy, we know that they're often admitted for neutropenic fever, and the first line are these anti-pseudomonal beta-lactams. And so in patients with a penicillin allergy, it might be nice to be able to use these medications. And so in their study, they had ID physicians actually on the team. So they had a team of ID physicians and pharmacists, and they tested basically anyone with a possible type 1 reaction to penicillin. And they included a total of 100 patients that they identified and tested. And so they found out that 95% of them were negative. So they had penicillin skin test and then oral challenge that was negative.
These were people who were history positive?
History positive, with a type 1 hypersensitivity, history positive. 4% were positive, and then 1% had an indeterminate result, so they had negative histamine control. And after doing this, after kind of delabeling these patients when they were admitted, a lot of these patients become kind of frequent flyers in the hospital. So 65 of these 100 patients were readmitted, with a total of 185 readmissions during their study period. And about 80% required antibiotics, as you would expect during their readmission. And interestingly, 93% of them got beta-lactams during these readmissions and reported no adverse reactions. So they did make a pretty significant change with this. They didn't report their initial baseline data, but probably a pretty significant change in the practices with these patients. And so there has been questions about blunted skin testing reactivity in similar populations and whether skin testing is valid. Studies have shown that neutrophils aren't as involved in the wheal and flare response, and so most experts agree that with a positive histamine testing is valid, and so you can trust that initial skin testing.
Who thought neutrophils were involved?
I don't know, but I think that is an argument used by some people to say, like, oh, we shouldn't do skin testing in these patients, but only one person had a negative histamine. And then I think, though, it's important to note, which I think you guys are doing as well, that probably the best time to test is not when they're admitted into the hospital after they've gotten chemotherapy, but prior to their immunosuppression. So if you can fit them into your clinic prior to their chemotherapy, prior to their high-dose steroids for their rheumatologic disorder or anything else like that, I think it's much more helpful at that point rather than having to do it when they're hospitalized and much sicker. And so one of my current projects is, I think, a project you guys similarly did of targeting the CF population, so patients with cystic fibrosis. So a lot of these patients have a listed drug allergy, about 60% of our population, and we have 115 CF patients at UCSF. And about 30% of our patients have a type 1 reaction history to any antibiotic. So our project targets penicillin, cephalosporins, and Bactrim listed allergies. And we picked these, one, because they're the most commonly documented adverse drug reactions in this population that could benefit from allergy testing. And then two, because they were the most commonly required antibiotics for the CF colonizers in our population based off of prior data. And I think what's made this project more successful is kind of addressing the common barriers that these patients have. So we basically embedded allergy providers into the CF clinic. So the CF clinic is already a multidisciplinary group of pulmonary providers, psychiatrists, dietitians, RTs, but we are kind of an additional part of the team now. We've also structured communication between allergy and CF providers, and so they ask us questions both before clinic about specific that patients may be coming in and about patients that they would like to have us evaluate that maybe don't meet those 3 antibiotic criteria, but they would like us to see. And then also outside of kind of clinic hours about specific patients that might be hospitalized, and we can just provide some advice there. And then we've also standardized documentation of the allergy plan, so it's much more easy for the CF providers to kind of see. We have the whole template of like what you should do if you want to give a penicillin, cephalosporin, Bactrim, vancomycin, and if it's safe or not safe for each patient. So in summary, we provided updates in Beta-Lactam allergy.
Do you
Yeah.
have any data on that last topic?
Yeah. So we started basically evaluating patients about in February, March of last year, and there was about 40% of the patients, of the 115 patients that met criteria of the antibiotic allergy. So they had a listed penicillin, cephalosporin, or Bactrim allergy. We've gone through about 50% of those patients so far, because some patients just are seen in clinic a little bit less than other patients, and have been successful. And we've only had like one positive challenge so far, but we've been pretty successful in delabeling the antibiotic allergies. I'll be kind of sharing more of that data at the quad. So, yeah, we provided updates in Beta-Lactam allergy. So Beta-Lactam allergy pathways, low-risk penicillin allergy testing, and delayed reaction penicillin allergy testing, and then updates in targeted testing in the oncology and cystic fibrosis population. Any questions? Yeah.
Do you have any comments on the blood test for penicillin allergy? Because our local reference lab claims that it's helpful, but I've been very unhelpful.
I've never heard of this before, so I don't know.
You
So
can
there is
order
an
a
IgE for penicillin.
Yeah, it's polylysyl penicillin or something, and I'll give you an IgE antibody against it. And my last two consults were people that the primary docs had ordered that it was negative. They gave them penicillin and they reacted, so it was really not very useful. But I just wondered if you've studied that in conjunction with any of this other stuff.
I've never heard of doing serum testing for penicillin allergies,
You know,
so
about
that's
10,
something.
10 years
Yeah,
ago,
when the PPL was not
Pre-10
available.
was unavailable. There was a manufacturing problem. And Mike Weiss is the guy in our group, I don't know if Mike is on the phone or listening, who made us aware that that test existed. So we, at that time, we had nothing else to do. You could only skin test people with native Pen-G. I don't have an answer as to how useful it was. Frank, do you know?
Well, I mean, I think statistically, we were hoping if it was positive, it might be helpful. No one was ever positive. Obviously fits
Me, it
with
was 0 for 2.
fits with the
Yeah,
data.
we did the same at the end, we never saw positive in vitro. But if there was, because we had no skin testing, we just recommend desensitization, a rapid
Right.
desensitization in a high-risk patient.
It was Quest is the company that offers that, and since you have this
Right.
group of really well-defined patients, I'd be just curious if you said, hey, will you test all these people and tell us who's really allergic?
Yeah, just ask them to get their blood drawn and see, yeah.
Yeah, the thing to do now is to find the rare patient who's actually positive that we believe has IgE allergy to penicillin and do the test.
Go backwards
See how
and
well
see
they
if it
correlate.
really is helpful. How did you test the Bactrim? Just like a strict puncture at full strength?
Yeah, a lot of the patients were doing more low-risk testing in, actually just direct challenges. But I think we've done like one skin testing so far, but most patients have these really low-risk allergies.
Right.
And so within their CF visit, which is already, 3 hours that they're there, we just go in and quickly give it, and so that they have no additional visits, which is really nice for these patients.
Mike Weiss sent me an answer, so he is listening. He said serologic test, which I presume means the IgE test, has a false negative result of about 25%. So that's what you found. You just happened to hit 2 bad ones.
0 for 2, yeah, mine was 100%.
All right, thank you, Mike.
Do you guys do Pen-G or any other minor determinants?
We just do Pen-G and pre-Pen. Yeah.
And that actually brings up another issue. For years, we've talked about having a commercial test for minor determinant. There was a time when I think the NIH was trying to bankroll that and make it available because it's always been a shortcoming. There are other breakdown products that we don't test. And There was even going to be a small company, I think, started out of Hopkins to try and make it. Anybody know anything about that? Mike will probably answer the question on my phone as well. So that's always been a shortcoming of our testing procedure. I don't have an answer, I'm just mentioning that.
Can you comment on the beta-lactamase inhibitor allergy? Because there's some concern initially with augmentin that the clavulanic acid caused a reaction. So we sort of added timentin into our skin test protocol to pick up the beta-lactamase allergy as well as a penicillin allergy. Do you guys look at that at all?
We haven't actually looked at that. I was just, when I was reviewing literature for this talk, came across that. But we actually don't test for that at this point. So I was going to bring that back to our group and ask those questions. Yeah.
I have a stupid infectious disease point of view question. Is there any way to predict Stevens-Johnson syndrome or DRESS?
Not that I know of, but I don't know if anyone in the group has heard of
Do
anything.
those patients have a history of prior reactions of any kind, or usually they don't have any history?
I think it can be either. Yeah.
People usually with renal issues or SLE, or anybody who has a decreased clearance or who's getting a prolonged course of antibiotics are higher risk. It occurs somewhere between 2 to 4 weeks, so we should be mindful in these patients.
That apply for SJS or just DRESS? My understanding was just DRESS.
Both of them, yes. I mean, SJS can occur more quickly than DRESS syndrome.
Thank you.
And HLH, I think,
Yes,
and more phenotypes are being added.
Any other questions? Well, thank you very much. All right, so we'll switch topics here. Mike did send me a response here. AllerQuest, I presume a biotech company, has gained tentative approval.
That's another idea.
This data published in JAMA, I presume, Mike, you're talking about a minor determinant commercial product.
Cool. Be nice.
So it's approved or?
I don't know.
I think it's approved.
Tentative approval is what Mike
Right.
wrote to me.
Great.
I'll get more information. Yep, that's what he said. Tentative approval for a
Right.
minor, we've been hearing that for 10 years, haven't we?
Mhm.
All right, so we're going to switch to part 1 of eosinophilic GI diseases. You may remember the first speaker of the year was on this topic with a molecule called Siglec-8 and antibodies against Siglec-8 being developed and looking very promising for treating eosinophilic gastroenteritis in particular. I think you're going to cover mostly esophagitis.
So we're going to talk a lot. I will probably, so I apologize. Hey, I'm Clint. I'm one of the first years. So I will probably not get through all of this. So you'll have to see my ugly mug again later in the spring to kind of close this out. I will talk a little bit about Siglec-8, just specifically to it. And a lot of the data that we know about, just because there's a higher prevalence of EOE, I will mainly be focusing on EOE. With some mentions of eosinophilic gastritis, gastrointestinal, or gastroenteritis, and then colitis at the very end. So I have no disclosures. This is what we're going to be focusing on. Like I said, we're going to be talking mainly about eosinophilic esophagitis. And then a lot of this is going to be pulled up from some pretty big articles that have come out within the last 2 or 3 years. I think it's important for us to kind of look at their GI doctors' clinical guidelines, because I think that there's no mention in their clinical guidelines of involvement of an allergist, and I think that is something that we will focus on. What is our role, as well as what our data has said about EGID or eosinophilic gastrointestinal diseases, as well as biologic therapies that are currently in study. So a little bit of the background of the history of EOE. So it was only first described back in the 70s and only became about 18 years later was then actually well described in the literature as a distinct entity. And then the framework for diagnosis only came out in 2007 So it's only really been a diagnostic criteria that has been established for the past 12 years. So there is some moving targets as far as this goes, and we'll kind of get into what that means. Initially, there was discrete types of EOE. We have removed that from the most recent guidelines in 2018, where the European, the US, and the pediatric guidelines were all blended into one, which is the agreed consensus guidelines. So a little bit of the epidemiology, it is male predominant. The current estimate is about 1 in 1,000 that are affected, and that is varying based on nationality. The Australian data says about 1 in 4,000. Europeans have it a little closer to 1 in 1,000. The US literature says about 1 in 1,000. Most of the patients are diagnosed in their late 30s, but they actually have symptoms as young as 10 when you go back and take the history. So it probably starts kind of early adolescence, but we don't actually get the diagnosis until they're 30. And about 10% of patients actually have a family member with EGID. And then the biggest and most important thing that I think that we need to be aware of is that 75% of patients have a history of atopy, and we'll come back into that. And then 50% of patients do not have peripheral eosinophilia, so just because they do not have peripheral eosinophilia does not mean they do not have eosinophilic disease, but that also means that 50% have met criteria for peripheral circulating eosinophilia defined by 1,500 cells per deciliter circulating.
You know, the peak prevalence in the mid to late 30s is a little curious because my recollection of the history of this is first really appreciating the kids, failure to thrive and weight loss, and you'll get into it, but to me this is a totally different disease in young kids and adults.
Yes, sir.
The kids are skin test positive. I won't steal your thunder anymore. Go ahead.
I'm just gonna give you the lectern, and you just do the rest of this. See you guys later. Yeah, so absolutely. So there is a little bit of difference in adults versus kids, both in management as well as kind of presentation. I think that based on the actual diagnostic criteria, so it does require a biopsy via endoscopy, which is where GI colleagues have to help us, and then pathology has to be involved to prove that there's greater than 15 eosinophils per high power field, specifically in the esophagus. Eosinophils are not native to the esophagus, so if you see them, they're never normal, but the diagnostic criteria says greater than 15 is what it's important to see. And it used to be that part of the diagnostic algorithm is you had to have someone on a PPI for 2 weeks and then biopsy, and that has been removed, so it's no longer a requirement for a trial of a PPI. We'll get to that because it actually has been shown to affect STAT6 as far as omeprazole, and so we'll get to that in management. There is currently work out of Northwestern as well as UNC that they're trying to have a defined clinical criteria that's based on history, that's based on endoscopic findings that you don't necessarily, you can make the diagnosis before you get the biopsy results back so that you can actually guide therapy, but that is still more on the research based, and we will kind of briefly, yes?
Does it require multiple biopsy sites, or can it just be positive on one?
Great question. So that's something that is technically still kind of debated. Right now, EOE, distinguishing EOE from GERD, GERD typically you have more distal esophagus where you'll have eosinophilia, and EOE you'll have it throughout. So if you have it kind of at the more proximal esophagus, it is absolutely EOE. If it's more distal esophagus, there may be some overlap with GERD, and that's kind of where the PPI responsive EOE kind of fell into, is that it would respond to it, but it wasn't completely consistent.
Has there been any speculation on why reflux would cause an eosinophilic infiltrate?
So I'll get to that in the pathophysiology. It's mainly because of mucosal damage that essentially allows signaling, which is my next slide. So that'll kind of go through the pathway of once there's mucosal damage, what is the signaling pathway? So similar signaling pathways to what we think about Th2 asthma actually occur at the mucosal barrier, but it's a little bit different, and hence why we have to treat it a little bit different. And then similar to how Dr. Altman had said, so most common complaints in the really young were feeding difficulties, vomiting, regurgitation, and then in the older patients, they typically see more abdominal pain, epigastric chest pain, dysphagia, odynophagia, and then food impaction is kind of pathognomonic for this. So when we go through the pathophysiology, every allergy lecture has to have the beautiful slide so that we all can look at this. So typically what we think is that there's a mucosal damage somewhere, either due to acid, due to food, due to something that kind of triggers TSLP through dendritic cells that signal through naive T cells, and that then begin to produce IL-5, IL-13, that then recruit eosinophils to the mucosa that causes inflammation. There's sialic acid binding immunoglobulin-like lectin 8. That's where cyclic 8 stands for. So for those of us that were there the first week, that's actually what cyclic 8. That's why we call it cyclic 8. It's sialic acid binding immunoglobulin-like lectin is a mouthful. That is specific on mast cells that then help signal to B cells to make IgE. And this is where some of our sensitizations kind of make a little bit of sense. And then mast cells and eosinophils with inflammation unopposed in the mucosa causes laying down of fibroblasts that then causes scarring and then dilation proximal.
I just want to point out to our head of ID how complex our specialty is.
We have graphs like that as well.
But ours makes less sense.
It's one of those things. Just get to learn all these fun words. So I still left the picture up there so we can all review it again, because those numbers are going to be important as far as the whole process, because those are where some of our medication agents are actually going to have an effect. So really taking a step back, it's probably not an IgE-mediated disease. It's probably more of a T cell, kind of a delayed reaction. But there is some level of these patients actually have an increased risk for IgE sensitization whenever you test them, and we'll kind of talk about that, with about 70% of kids being skin prick positive for IgE testing to foods. That does not mean they have IgE-mediated symptoms, but they are sensitized to it. And then around adults, it's about 50% in some data. And so does not mean that if they eat milk, if they eat legumes or tree nuts or anything like that, that they actually have symptoms. But if you test their skin, they are skin prick positive.
I don't think that's true in adults. I've never had a skin test positive adult.
Too high.
To food.
I agree.
That-
Too high.
Well, unless they have OAS.
If they have some other
Could be
disease,
relevant.
but if they're just working them up for EOE and you test them
Right.
to common foods, they're negative.
No.
I'm literally just reporting what Dr. Wexler out of UNC has published. That is his data that says that he says 55% of adults greater than 18 actually are IgA positive, either in serum or in skin prick. That is his data. I'm not going to try to defend it. I apologize if you disagree with it. There is some actual seasonality for EOE symptoms. So some patients with grass sensitization, and the theory is that it causes postnasal drip that goes down and irritates the mucosa. They actually can have an increased symptoms during the summer months. And then there are some patients that are on oral or sublingual immunotherapy, with the highest estimates being 5% actually can have EOE diagnostic based on where they are later. And there's been about studies out of DC that show that over a 4-year period of time, as the pollen counts for grass rose, there actually were flares of new diagnosis of EOE, and so that's where a lot of that data comes from. So the goals of therapy, mainly from the GI side, but also from our side, is kind of two-pronged. So obviously we want them clinically to feel better, right? We don't want them to have symptoms. And then histologic remission. And there's a lot of argument from our colleagues in the GI specialty about which is more important, clinical symptomatology or histologic remission. Because in theory, if you can induce histologic remission, you're not going to have laying down of myofibrocytes, and so if you don't have fibrosis, then you're not going to have scarring. If you don't have scarring, then you're not going to have dilation, and then you're not going to have to intervene. But that's never been kind of borne out of histologic remission is more control, is more important than symptomatology. And only within the last 2 or so years do we actually have a standardized, validated scoring system, which makes a lot of the data, specifically when we talk about some of the biologic agents, actually important for us to understand, because there has not been validated scoring systems for either side. And that's kind of one of the challenges. And then uncontrolled fibrotic scarring then can require dilation, can actually cause dysmotility, can have to require resections.
What percentage of patients go on to have that?
So it's technically less than 10% is what the GI doctors say. But that's also one of the things that since it's such a new entity, they don't have a great answer for what's putting someone at increased risk for scarring to cause dilation. And it's only really been, since most of the patients currently are diagnosed later, they don't know if you have symptoms at 10 years old and it's uncontrolled for 20 years, does that put you at an increased risk, or does a new onset presentation with food impaction cause you more problems? We don't know. So the management per all of the GI guidelines, as well as what came out from Jackie in Practice last year, is it does require a multidisciplinary team. There is a gastroenterologist who is primary, as well as a nutritionist to help guide dietary changes, as well as a primary care provider to help kind of be the go-between to make sure that they have frequent follow-up. Once again, you'll notice that there is no allergist listed on there, and it's mainly because when we kind of move further down into the elimination diet, our role is a little bit more kind of a gray area at this point. So the first step for therapy for all patients with EOE, and the algorithm for how you typically approach it or should approach it is that blurry thing in the right side that most people can't read, which us presenters always do on purpose. So the first therapy is high-dose PPI, 1 to 2 times a day. There's better data to say that if you do it twice a day, that you are able to induce remission a little bit faster. And then so some of the estimates say up to 50%. You're actually able to get histologic remission based on just treating with a PPI alone. That does lump together the PPI responsive EOE with all causes EOE, and that's a little bit more challenging. They don't break it down to say if you have EOE that's diffuse, you have a less likelihood that you're going to respond to PPI. They don't break it down, but just in general, 50% of patients with EOE are able to get into histologic remission, and then sustained remission occurs in about 75% of those patients.
Clint, is that like 2 to 3 months of therapy?
So sustained remission is defined as greater than 6 months.
6 months.
And then, like I said, so we've removed PPI responsive eosinophilic esophagitis as a separate entity or as a diagnostic criteria before making the diagnosis of EOE. It is all EOE.
If you stop their PPIs, does it come back, or are these people quote cured?
It does. It can come back, and that's one of the challenges. And that's where we see it more in the steroid patients than in the actual PPI, because it's a little bit easier to have someone on a proton pump inhibitor than swallowed steroids, just because of the side effect profile. But typically, you can stay on maintenance with a PPI for a long period of time without having symptoms. With steroids, you will most likely have symptoms within a few months if you're on it consistently and doing it right. And so most patients then don't come off of the PPI therapy, but they may come off of the steroid therapy, which is one of the kind of reasons that we see more relapses in steroids. The next line of therapy is swallowed topical corticosteroids, and there's 2 major preparations. There's fluticasone propionate, so the inhaler, we do 2 puffs. You do 4 puffs to 8 puffs twice a day without a spacer. So everything we tell our asthma patients not to do, they actually do want them to swallow it, and so it does get in there. They can only really induce remission in about 60% of patients that are not in the PPI responsive crew. And then budesonide, so it's more of a slurry. You mix it with some level of sweetener that's not terrible to swallow. And they swallow somewhere between 0.5 once a day in pediatric patients up to 2 milligrams, and then you back it off. So you higher dose and then you back off to half that for maintenance to try to keep them on maintenance, but still many patients fall off. And that's higher as far as histologic remission rates. It's probably in the 50%, but both of their relapse rates are about 65 to 70% as far as their relapse rate.
So I know Mike Weiss does thicket with the budesonide instead of the Splenda,
Mm-hmm.
so you can do that. Just because I think then you're not getting some patients don't like all that Splenda and that sweetness. And then there's Evan, it's the Dellon guy.
Who's at UNC?
Yeah, so he's just written some articles about keeping people on budesonide long term, and really, if you talk about side effects, it's kind of like asthma. You know, you look at their adrenal access and blah blah blah, and really they're not seeing it. So I mean, to be honest with you, I think sometimes if they're responsive to like a budesonide, you want to go down, but if you go down too low, then they relapse. So you know, sometimes it might be like, I think 1 milligram per day is.
So for adults, it's recommended 1 milligram per day for maintenance, and for pediatrics, it's 0.5 milligrams. That's the recommended, but there's still just. It's just like other asthma medicines. If you're not taking your controller, you're not going to have relief. Similar for EOE, you will have relapse if you're not on it. Yes,
Is
sir?
relapse defined as histologic?
Yes.
Or like, so it's all, like, there's no, like, none of it is based on symptom control or, like, any other testing modalities?
So
aside
it's
from going back in
typically more on histologic. Yeah.
I didn't know there were budesonide effervescent tablets. Are they in the U.S.?
No.
They're not.
No.
I just wanted to mention them because they are available over in Canada, and you can get them internationally, but unfortunately, we just have to use the Respiels.
Well, we get a lot of meds out of Canada. I send, we get patients, I'm sure the rest of you know, there are Canadian pharmacies that just mail drugs across the border. Proper drugs.
And probably the management that has the best data behind it is actually the elimination diet. And that's probably where we can come in a little bit more. So the biggest role as far as an allergist in food allergy testing in patients with EOE, like I said, so this is not my data. This is data that has come out of from other institutions. Is that they say that pediatric patients are either serum specific food IgE or skin prick positive in around 70 to 80 for pediatric. Or adults is roughly 50%. It may not be what we see clinically, but that is what the data supports. But the validity of those tests is really called into question. Specifically, the thought was for HB patch testing is that would have better prediction for patients with EOE, just because this is a delayed reaction, so therefore a delayed test would be a better test. But because of non-standardization, the sensitivity for all comers for food allergy for atopic patch testing is around 50%, and in patients with GI, it's about 57% in a recent meta-analysis that came out in 2019. And then the sensitivity is probably like 91%, but there is not standardization in what the concentration should be. There is not standardizations in what the results are considered. So that is something to be considered. And then there's a CHOP database for pediatric more specifically, but also that's been used in adults, that has positive predictive values for each specific food test. And when you look through it, the average positive predictive value is probably around 44 to 46%. So it's actually like, if it's positive, it's helpful. So a lot of the skin prick testing, a lot of the food allergy testing is not beneficial. And once again,
what are the foods that are usually implicated in this?
Great question. So we're going to get to that in elimination diet. And I'm just going to take a step. I promise you I will answer that. I apologize.
We only got 4 minutes.
Well, that's good, because the next slide is going to be the last one I stop on. So whenever we look at a lot of the elimination diets that are guided by food allergy assessments, initially in 2005, Spergel et al. Showed that in pediatric specific patients, you were able to induce histologic remission in clinical symptomatology just with dietary avoidance of specific IgE-mediated food or IgE-sensitized patients. But every subsequent study has said, we don't think that's accurate because it has not been able to be reproduced. So as of right now, diets that are dictated by skin prick testing or serum specific have not actually been shown to be beneficial in inducing remission. So my last slide that I will kind of talk about, and it's mainly because this is where we see a lot of patients, is the elimination diets. So the most common food culprits, kind of in order as we go down. So it's animal milk protein, so dairy, and then wheat/gluten, then egg, then soy legumes. And there's specific diets that help kind of progressively avoidance, and then that can actually induce elimination. Each one, the more restrictive it is, the better the outcome is as far as inducing remission, but the harder that it is, with the best being empiric elimination of all element, or so it's an elemental diet. It's essentially like you're drinking like Soylent, if you want to reference that, but it's essentially an elemental formula that you have to drink for all of your meals. It's the least palatable. It is the best at inducing remission, but it is the least adhered to. And this is where our colleagues with nutrition have to help us. And then there's empiric dietary restrictions. So there's the 2-food, the 4-food, the 6-food. Where the 2-food, you just avoid dairy and wheat, and you can get it to histologic remission around 43% for both adults and kids. 4-food is when you add in egg and soy, and then you can get it to about 54 and 64% for pediatrics. And then 6-food, you also add in peanut, tree nut, and seafood, and that's where you kind of get up into the 70% remission. And once again, this is talking about histologic remission. We don't know which is more important, histologic remission or clinical symptomatology. That's still kind of debated. Problem with all of these is all of them, the recommendations per the guideline is after you initiate a diet, you give it 2 to 6 weeks, and then you do re-endoscopy. So you make sure that you have a baseline of, now that they're avoiding it, you re-endoscopy. And then after that, you add one food back in, and every 2 weeks, you add a new food in, and you re-endoscopy. So it is a very endoscopy heavy, a really endoscopy heavy process, which is not clinically ever done.
Are these kids going under anesthesia when they're?
Yes.
Or is it conscious sedation?
Yep. It's usually anesthesia. And they're trying to find ways, and we'll talk about that kind of more in like the researchy side, which will probably be in the spring, because I'm running out of time. That they're trying to find different ways like nasal endoscopy, with string testing, where you just literally put like a pH probe down. But as of right now, all the guidelines say you have to re-endoscopy with each new food introduction, which is not done.
Colorado Children started like 2 years ago. They do nasal endoscopy, and they're starting to train other peds GI, because one of our EOE peds GI person was going there. I don't know if they actually started doing the nasals in the peds clinic, but at least you don't, like, it's like it was with ENT, and so it at least avoids a general sedation. It's a lot shorter. So some families were electing to go there just because they could do it that way, but it's a whole lot.
So the question is, should we skin test people anymore? It's of no value.
I've gotten so many referrals.
So the current recommendations from Steinbach in 2018 from Jackie says skin prick testing should not be done.
What?
That skin prick testing should not be done because it does not guide. Empiric elimination diets are more beneficial than skin prick test guided diets. So we should not be skin prick testing.
Yeah, I agree. The only problem is we get referrals from GI docs specifically asking us to skin test people. It's sort of insulting to write back to them and say it's not necessary.
Well, I feel like
that's also from their data has published. So their guidelines in 2017 or 2018 said that skin prick testing should not be done. That is their guidelines.
And like I don't know, we used to do it also just for the fact that if you truly are eliminating these things and they do have a sensitivity, then the thought is if you're doing truly strict elimination, which is variable if people are actually doing that or not, then we kind of use it as a way, like if you decide to reintroduce that food, you should reintroduce it in clinic maybe, just because they do have a sensitivity. And so if you're truly avoiding it for a period of time, you might develop anaphylaxis.
Spoiler. That's next time.
Yeah.
Golly, I'm just gonna have you guys give my talks from now on. Yeah, so that is the one benefit of could you potentially have skin prick guided reintroduction, similar to the patients that were prior to the LEAP trial with peanuts that were shown that avoidance leads to sensitization, is potentially these patients where you instruct elimination, that reintroduction should be guided by them.
Just a comment on Lynn's comment, I think most of our GI guys refer them for allergy testing because they don't want to manage them. So they basically send them to us so they don't have to see them again unless they get to endoscope them. That's sort of my impression of our GI referral
Yeah.
pattern in
Well, in
Everett.
the real world, these people, I don't think, get the current endoscopy.
They don't.
Get a diagnosis,
Yeah, I
and
mean-
then they're done with them, and
That's what I think. I think they just want to
I tell
unload
them
them.
to
I think-
avoid wheat and dairy, and
I feel like a lot of our role is education, because a lot of them come to clinic, they don't know about the diagnosis,
They've been
so.
told to have it and go see
So-
allergy.
That's how I justify skin testing, I place it and then I just talk with them about the diagnosis, because that's why the GI docs send them to us, but yeah.
And I think I get 80% less like from children's, but the ones there's a history of a problem with the food unrelated to the EOE. And sometimes I think that can be beneficial. So a subgroup, but a small subgroup. It makes sense. I was going to ask you on the elimination diet studies, I'm assuming they were not allowed to have any pharmacotherapy.
So they actually were, you were allowed to be on pharmacotherapy and then they still did elimination diets.
So you could be on PPIs?
You
Because
could.
if you look at the answers, the same as being on PPIs
Yes.
alone. So
And that's the biggest thing.
like
Is,
a 50% remission with PPIs.
and so, and that's one of the things is that most of the elimination diets, if you
Doesn't
do
really
both
help.
therapies at the same time,
Right.
you're actually able to get them off of medications and you're able to just treat them with an elimination diet alone.
There's a slight synergistic effect.
the other thing that's fascinating about this disease is that when we were young, it didn't exist. And the only eosinophilic GI disease was mostly gastroenteritis, which was very rare.
Mhm.
And then this disease came out of nowhere and has become far and away the dominant and almost exclusive eosinophilic GI disease.
Did not exist,
That's
so they
the-
just not label it.
Yeah, that's the
Yeah.
question
I
I
mean,
have.
I think oftentimes, having practiced as just a primary doctor for the past year, like a lot of times it's hard to diagnose this because a lot of these
That's
gentlemen are coming in with chest pain, they have cardiac comorbidities that you think that they're having like MI or something like that, so you're missing the diagnosis potentially. Or frankly, it's just very commonly diagnosed.
Insidious.
There's another anecdotal piece that there is a study done that looked at the incidence of pediatric endoscopy versus a diagnosis of this disease. And they didn't ever endoscope little kids back in the 70s, and they started endoscoping them more and more frequently, and all of a sudden this disease has come up. Did they ever acceptfully say that that's the answer? Or is this disease really truly a new instance, or is this just more diagnosis because of 1,000-fold more endoscopies?
So the way I kind of conceptualize, so there's not good data to say like it's because we're doing more endoscopies. I kind of think about it similar to, so I was a general pediatrician before I came into allergy. It's similar to autism spectrum where we now have a better defined criteria. We have a better defined protocol for how to evaluate. So now we're diagnosing it more. It's not that the incidence has changed, but we now have a better diagnosed protocol on how to do it and approach it.
That makes more sense, that it didn't just appear, it's just we finally picked it up.
That's the thought right now. But there's no data to say that.
If you don't look for it.
Can't find
Well,
it.
the scopes, we got, used to be way back when solid, non-flexible scopes, so doing a procedure in a kid would be probably impossible.
Yeah, that's true. I just remember watching EGDs 30 years ago, how barbaric it was. Now it's like, yeah, just put a scope in and it's no big deal.
And I feel like it's hard, I don't know, I feel like some of these patients, particularly the adult patients, they're so used. I feel like even when you ask them their symptoms, they all endorse all these symptoms, but it's so common for them, like you're just so used to it and that's your life and that's how you eat and you don't even think of it as a symptom to begin with until people actually start asking you the questions, that I feel like it's so like I've had a couple people who are like, well, I don't want to do any of this, like why I don't have any symptoms, because for them it's it's so commonplace, like they don't know anything else, and so they're not going to report it, and they don't want to comply with this stuff because it's hard, and they don't feel any different
Well, like you said, it's the ones that they go to urgent care
Yeah.
because they're like,
until they have like a food
yeah,
infection.
and that motivates people,
Yeah.
but
They
otherwise.
get the chicken fished out, that takes them to
Yeah,
the
it's like-
doctor.
Yeah, happy Turkey Day, guys.